systemic therapy, especially target therapy for melanoma. And as you probably know, the patient with advanced melanoma used to have very bad prognosis. When you talk about survival, I think many doctors will quote the old saying that patient stage 4 disease melanoma has 6 to 9 months to live. And in some of the doctors still will say that you have metastatic melanoma, forget about it, go enjoy your life, and then when time expires, then that's it. But then, these days, things have changed dramatically. In fact, among all the cancer types, I can't imagine anything made much change, faster change than melanoma. So it's very kind of high, good time now to talk about. And information is coming on so quickly nowadays. So every few months, we have new information. So I'll talk some of the most updated information on target therapy and what else is happening in the world. So once again, before 2011, very poor limitations of the treatment options. Dacarbazine was the old standard treatment in 1975, but there's no evidence dacarbazine actually extends life of patients with advanced melanoma. 1998, interleukin-2 was approved, and some of you might have received interleukin-2 in the past, and very harsh treatment. Patient has to be in the hospital for 7 days, and they have significant weight gains, heart problems, kidney problems, and the weight gain problems as well. But problem is that despite all these treatment side effects, the long-term survival is very poor, and in general, only 6 to 9 months of survival time was recorded. We need better. Since 2011, there are 8 medications approved by FDA based on improvement in survival and possibly improvement in cure rate of these medications. And half of these medications are so-called targeted therapy, and the other half, the immune therapy. So the question is, what is target therapy? In general, there's 3 categories of treatment in advanced melanoma. One is called chemotherapy, and we all know what chemotherapy is, basically poison to fast-growing cells. Immunotherapy, that Dr. Miner will talk more in depth a little later, using your immune systems to fight tumors. And third category is called targeted therapy. It's also called molecular therapy. And many people refer this as the personalized medicine, customized medicine, precision medicine. So let's talk about this. Definition of targeted therapy is a type of treatment that uses drugs or other substances to identify and attack specific types of cancer cells with less harm to normal cells. Some targeted therapies block the action of the certain enzymes, proteins, or other molecules involved in the growth and spread of cancer cells. Sounds great. In the perfect world, if target therapy works, it should be harmless to patients, yet tumor cells die. That's the perfect world. But it's not there yet, so it can have some side effects as well. In general, the success of target therapy depending on 2 factors. One is, can we identify certain proteins or molecules or genes that are responsible for tumor growth and tumor spread? And second factor is, can we develop the right medication for those abnormal proteins and genes? That's something we have to go for. If you look at literatures and in the magazines, you can see a very complicated graph of the cancer cells. So typical cells, cancer cells, can have tons of proteins feeding into the nucleus so its cells can grow. And we have to delve into what's important. And some of them may not be relevant to melanoma. Some proteins may be relevant to melanoma. So one of the most studied pathways or proteins is called MAP kinase pathway in the red square, but it looks complicated. So if you look at a little more simplified form, you can see this is the cell. The green line is the cell membrane, so outlining of the cell. Underneath is the inside the cells. And 2 of the most studied is called MAP kinase pathways on the left side, also PI3-AKT pathways on the right. But still, we believe, as of 2017, MAP kinase pathway on the left is more relevant to the treatment of melanoma. So we'll talk about that. These MAP kinase pathways basically chain reactions. So when certain proteins are abnormal and turned on, it can keep having chain reactions to activate other proteins, and ultimately tumor cells grow and spread and survive. Two of the most commonly mutated genes, meaning that there's DNA changes happens, is in the BRAF and NRAS proteins. And Dr. Kashani briefly mentioned earlier, the BRAF mutation occurs about 40 to 50% of the patients, and NRAS mutations occurs about 20% of the patients. And interestingly, they don't work together. They don't go together. Either you have BRAF mutation or NRAS mutations. That makes almost 70% of the patient will have mutation in this protein or this protein that drives the pathway this way. We don't want that. When this pathway is active, that means tumor is happy, tumor is going to grow. We're going to stop that. So what we do is having this, what can we do about this BRAF mutation? Can we design a drug that can go to this BRAF and then block this action of the BRAF? If we do it, we can block the pathways down, block the pathways, then no more tumor growth, no more spread. Sounds good. In fact, about 10 years ago, there's a small biotech company called Plexcon across the bay in Berkeley. They have a technology to design certain drugs based on how these abnormal mutated proteins look like. So they designed a drug called vemurafenib, also called Zelboraf, and some of you may know about this medication. It's when they try this medication in mouse, it looks wonderful. Just like other medications in mouse, you can cure mouse. But then in human, more challenging. So they did this clinical study in phase 1, first in-man clinical study about 10 years ago. They found that after 2 weeks of treatment, you can actually see in the tumor samples, tumor biopsy samples, all the proteins relevant in this BRAF signal pathway is shut off. So here the brown stain, it indicates that what happens in this pathway, more brown, more active, less brown, less active. After 15 days, a lot of activations went down in the tumor cells itself on the biopsy. In fact, during the phase 1 clinical study, we had teleconference every week to what's happening with the patients in 6 sites across the United States. Interestingly, after 5 days of treatment, you can see patients' tumor shrinking. They can see in their eyes, 5 days tumor shrinking. One patient was really have hard time walking because of tumors in the lungs. After 1 week of treatment, no more oxygen necessary, they're walking better. So it cannot be true, it's too good to be true. Even IL-2 couldn't do that before. So that was successful phase 1 study. Move on to phase 3 clinical study. They showed, let me show some of the pictures from the phase 1 clinical study. A patient with a significant liver metastasis, after 2 weeks of treatment, activity is almost gone. Another patient with lung and pleura medication, the metastasis has improved significantly. Third patient with liver metastasis, spleen and lymph nodes, much better. Fourth patient with a widespread disease, all the black studied with a tumor, has pretty much gone away after 2 weeks of treatment. So it looks wonderful. Led to phase 3 clinical studies. Let's compare this new drug versus old standard chemotherapy called dacarbazine. And the result was phenomenal. So in terms of tumor shrinkage, it's called overall response rate. Basically means how many of the patients have significant tumor shrinkage. So tumor volume becomes half or less with this treatment. That occurred only 5% with the chemotherapy versus 49% with the vemurafenib. Even survival was 13 months of median survival, meaning average survival was 13 months compared to 9 months with the chemotherapy. And if you look at the graph, more spacing between these two lines, the vemurafenib versus chemotherapy means more difference in benefit, showing that tumor control and also survival was better with the vemurafenib. So in 2011, FDA said this is good enough, it met the primary objective, it's approved. And second medication, same target, similar approach from different company called dabrafenib, also called Tafina, was tested. Very similar results. When you look at the response rate, it was 50% of dabrafenib, tafina versus 6% DTIC chemotherapy. Once again, tumor control was much better with dabrafenib. So in 2013, drug was approved by FDA. So now we have two medications that target BRAF mutations as of 2017. But here's the problem. Many patients, they do well for the first few months, but many patients start having resistance of tumor only after 6 months or so. So average, so-called median tumor control time is only about 6 to 7 months. And the patient we just showed early on who had wonderful liver response after 2 weeks, only after about 16 weeks, tumor got worse again. And unfortunately, the patient passed away because of the tumor progression. So what's going on here? So our goal was trying to block this BRAF, block these pathways. But then something's happening. Somehow it's turning back on again. So what's happening here? So since 2012, a lot of people were interested in finding out the mechanisms, what's going on. Can you find out about it? What they found is that sometimes tumor cells want to survive, so they struggle. They make different mutation changes in their genes so they can survive the medication. They can develop new mutation and NRAS level that bypasses BRAF and goes down and activate the pathways. It could be change in the BRAF itself, so it doesn't bind to this drug. So the drug doesn't get into the tumor cells. That's another problem. Also, it can be another mutation of other proteins in these pathways. So even if BRAF is mutated, activation of the MEK can drive pathways anyway. In some patients, they use the sister RAF protein called CRAF, goes around and cause problems, and other proteins can activate. And sometimes even in the receptor, meaning in the cell surface, protein can be changed. They can activate the pathways in two different pathways. But in majority of patients, this is the same pathways, the same problems. So meaning the tumors make some changes. It can bypass the BRAF signals to activate the pathways so cells grow. The strategy is can you block down these pathways even better with two different medications? So BRAF we talked about. There's new medications called the Imatinib or Imatinib. Imatinib is called the Mekinist. Imatinib is called Kotalik. When you combine this BRAF and the MEK protein itself, maybe we can block these pathways even more completely. They may can do a better job. In theory, it makes sense. In mouse studies, it makes sense. So the question is, can two drugs versus one drug, does it make difference in human? That's a big question. So phase 3 clinical study was conducted in the United States and European countries. So there's 3 large study was conducted. Same principle. Dabrafenib plus trametinib is a 2-drug combination. They compared with the old standard, which is vemurafenib at the time, showed overall survival of patients was better with combination versus single agents. And you can see the gap is obvious, meaning that there's enough difference between 2 drug versus 1 drug. And second trials, totally different trial, using the same drug, this time versus dabrafenib, same result, improvement in survival. 30 studies, now this time using vemurafenib and cobimetinib versus vemurafenib, same concept, also result is similar. All 3 studies in the world show the same result. When you combine 2 drugs in human, they have better survival, better tumor control than doing single agent alone. So with this information, it's pretty obvious. Now everybody accepts. When your patient has BRAF mutation, let's use 2 drug combination, not 1 drug. Okay? But then there's always exceptions. Some patient will say, well, how about 1 drug may be simpler to take. I don't have to worry about 2 different medications. So is it possible if patient gets only 1 drug, can they do well for a long time? Absolutely. Some of the patients that of mine and also Dr. Minor and I shared, some patients only 1 drug for 5 years with lung metastasis and then bone metastasis, still doing great 5 years out with only 1 drug alone without resistance. So in some patients, even 1 drug can be great, but on average, combination is better. So there's misconception or conception that when you do the target therapy, it may work wonderful, but it doesn't last long. Maybe it's true for some patients, but not for everybody. So when they did updated in the data analysis about 8 months ago, what they showed is that when you do this combination of the BRAF inhibitor plus MEK inhibitor, actually 44% of the patients are alive at 3-year period, which is quite phenomenal compared to old chemotherapy that most patients will not make 3 years with this disease. So, and many of the patients still on the same medication 3 years out. So look at the curve. After 3 years, it may possibly plateau, meaning some patient may do fine for 5 years or beyond with target therapy alone without immune therapy. At this point, we don't know which is better. Immune therapy is better, target therapy better, but patient may be different. Some patient immune therapy is better, some patient target therapy better. So we have to do a better job in the future. How can we tell for certain patients should you go with a target therapy or immune therapy? And there's a lot of research going on. How about those patients, unfortunate patient who doesn't last, didn't live too long with this target therapy? A lot of research going on. Maybe it's different pathways may be important. So can we combine these two medications plus third medication, just like HIV experience? One drug is better than nothing. 2 drug HIV medicines better than 1 drug. 3 medications, now people live for decades with HIV. So maybe in cancer and melanoma, maybe the same concept. So we'll see. Patient comes and say, I don't have BRAF mutation, what am I going to do? Well, what other mutations are available? NRAS mutation, as you said, is another common mutation, about 20% of skin melanoma. And it's activated the same pathway as well. Unfortunately, there's no drug that blocks NRAS. So the strategy is, can you block downstream pathway called the MEK? Then maybe that may work better. So a drug called Imatinib, Imatinib, and also the Imatinib has been tried. And the concept is block this pathway. In the phase 3 clinical study of new drug called Imatinib compared to chemotherapy for NRAS mutation patients, this time we're not talking about BRAF, but NRAS mutation, showed that there's some improvement in tumor control. So if you look at the curve, but how about half of the patient, how they do it, tumor control was longer with the Imatinib versus chemotherapy. Response rate, 15% of the Imatinib versus 7% of chemotherapy. So numbers look better. Some signal it may be better, but the main question is overall survival. Do people live longer or not? Unfortunately, the study was negative in this regard. The survival was no difference, chemotherapy or this treatment. So in my view, this MEK inhibitor, these medications is a good start, not good enough to make major impact in people's life. We can build on top of it. In fact, that led to the second study. Can we combine the Imatinib plus the second drug called LE011? When it's combined, LE011 is another pathway blocker called CDK4 pathway. When block these 2 pathways, now you can see response rate up to 41%. It was announced about 6 months ago. So certainly we can see improvement in tumor shrinkage. And the study will probably go into phase 3 clinical study in the near future. So if it's positive compared to chemotherapy, there could be a new paradigm shift for the NRAS mutation patient treatment. So we are hoping that soon we have some good result. And this is the study. Some of the patients had dramatic improvement in tumor size. KIT mutation, rare among skin melanoma, but in patients with a mucosal melanoma that occurs in the mouth, inside the mouth, in the rectum, about 10 to 20% of the patient has KIT mutation. If that's the case, if you have the drug called the Imatinib that blocks this pathway of KIT, the proteins, we can block these pathways. So the clinical study was conducted. There were 3 clinical studies using Imatinib for patients with KIT mutations. They found response rate meaning significant tumor shrinkage, occurs about 33 to 53% of the patient, which is quite good. And you can see the changes. So tumor here in the pelvis looks significantly shrank, and also signals in the pelvic area decrease significantly, showing that tumor is under control. Patient with number of the metastatic disease in their legs has much improved. In my view, that's early success, but then it's not as good as it should be. Tumor control time is relatively short. Only 4 months after, half of the patient tumor gets worse again. So in my view, that's a good start. Maybe you have to add on top of this KIT mutation inhibitors to make it more impact on this patient with the KIT mutations. Another mutation is called GNAQ mutation or GNA11 mutations. Once again, it's very rare among patients with a skin melanoma, but in patients with melanoma of the eye, called uveal melanoma, it's very common. Almost 80-90% of the patients have this mutation. This protein is in the cell membrane proteins. So when it's mutated, it's known to activate the MEK kinase again. So if you block with the medication of the MEK inhibitor called Imatinib, you can block the pathway and MEK can do some good job. Phase 3, the 2 and phase 3 studies so far looks, I'll say, very moderate success only. Response rate 15% with this new medication versus 0% of the chemotherapy. And to remind you, the uveal melanoma is notorious that the therapy doesn't really work well in general. So traditional chemotherapy doesn't work at all. But when they try to combine, let's try combine chemotherapy with this new medicine, maybe it'll be better. But unfortunately, when they combine it, there's not much of activity in patients with a uveal melanoma. So still, even though we have some signals, maybe some really modest success of this medication for the uveal melanoma patients, it's not as good as of yet. We need something better. And nowadays we do, and that's many centers do so-called next-generation sequencing mutation analysis. And basically what it does, we don't just check BRAF mutations alone. We don't only check NRAS mutations alone. We check hundreds of genes at the same time, so you can have different informations. And as you said, small number of people don't have BRAF mutation, NRAS mutations, or KIT mutations. In fact, we have an example of what this technology can help you. At a patient, 81-year-old gentleman with metastatic melanoma involving the multiple area of the lymph nodes, liver, and the spleens and lungs. And in the past, patient received different immune therapy called nivolumab, ipilimumab, also called Opdivo and Yervoy. This patient received TVAC, herpes virus melanoma vaccines on top of the PD-1 treatments. Also radiation therapy at certain spots, but tumor, nothing responded. Tumor still getting worse through all this immune therapy. And there's no good treatment options except chemotherapy, which is quite poor. In his case, the mutation testing shows no BRAF mutation, no NRAS, no KIT mutation. But we found very rare mutation called the protein change called RAF1 fusion change in the genes. And preclinical data, all the scientific literature shows that if you block the same MEK kinase pathways, it may work. There's no human experience so far. So I talked to patients about, there's a drug called Imatinib mechanism. Let's give a try. He understood there's no data, but he wanted to do it. Fortunately, insurance company understood. They gave approval for this medication. So he started in November 2016, so not too long ago. Big tumor in the neck, lymph node here. He has the big lymph node in the chest, the liver as well. 2 months after, I got the CD report showing that the tumor here shrank significantly in the neck. And liver, the big tumors now has become small. Chest, some modest improvement, but inside the liver, big dark spots there looks much smaller, only 2 weeks after. In fact, local oncologist was saying this is the dramatic improvement. So I didn't believe it until I saw the CT scan myself. So this is an example that how this new technology called next generation sequencing can help patients, even if they don't have BRAF and NRAS mutation. So I think this is the beginning of the new era. Maybe in the next few years, we'll know more about these mutations and more about new medications. Maybe some good success story will come. And Dr. Kashani has a program called Avatar program. I think it can help in the improvement of target therapy in the future. So patient will have a tumor harvested from the body, and we'll do analysis of all different mutations as we talked about. And if I can find which mutation is relevant for that patient, which may be different from person to person, we can identify potential drugs for those patients and test in mice with the same tumors from the patients. If we see some success in the mouse for that patient of the patient tumor, then it can be given to patients itself. So I think that can be very so-called personalized precision medicine. Is the exact how we have to approach. In summary, BRAF mutation is so far it's a success. The combination of these two drugs of BRAF and MEK inhibitors has improvement in survival. And a little less than half of the patient still living 3 years with this treatment. NRAS mutation, some early leads that maybe MEK inhibitor can be an option, and maybe even combination looks very promising at this point. KIT mutation for the mostly oral and mucosal melanoma, MEK inhibitor is a good start. We're not there yet. We need more studies on this. And GNAQ, GNA11 mutations for the eye melanoma, we're not there yet, but we're making small difference at this point. So with this, I'll conclude my talk, and we'll talk about some of the questions you have at the end of the session later today. Thank you.